Well, hello, everyone. I'm Candy Hansen, a nurse with Superior Health Quality Alliance. Thank you for joining us for today's webinar, Using Effective Fall Prevention Strategies in Nursing Homes, a Pharmacist Perspective. We are thrilled to have pharmacist Matthew Palmer as our presenter today. Matt is a board-certified geriatric pharmacist. Today's session will be recorded, and the slides from this session will be sent out after our event. There will be a link to an evaluation at the end of our presentation that we would appreciate if you would complete. All participants are muted. Please put your questions into the chat. Jessica Newsom will be monitoring the chat box and will facilitate questions and answers at the end of the presentation. Our objectives for today are to review medications that contribute to falls in the elderly, review the pharmacology of medications that contribute to falls, and describe pharmacological interventions to reduce falls. This is for Matthew Palmer. Dr. Palmer is the manager of clinical operations for PharmAmerica. He provides and oversees clinical pharmacy services to skilled nursing and assisted living facilities throughout the region. He is a board-certified geriatric pharmacist with over 17 years of experience in the long-term care arena. He has a Bachelor of Science from the University of Wisconsin, La Crosse, and a Doctor of Pharmacy degree from the University of Wisconsin, Madison. Dr. Palmer, I'll turn it over to you.
All right, thank you, Candy, for that great introduction. Appreciate it very much. Thanks everybody for taking the time to be on the webinar with us today and talk about pharmacological strategies that we can use to reduce falls in our elderly population, especially in our nursing home folks. And I'm going to start off with a slide today about polypharmacy, what if? And the take home from this slide that I want you to kind of keep in the back of your mind while we go through the rest of the slides and the talk today about various different medication classes and how they can contribute to falls and strategies we can use to help eliminate or decrease them. But I want you to just remember that every additional medication we add to a resident's medication list increases the risk of an adverse drug event by 7 to 10%. So again, each additional medication, it doesn't matter what class it's in, but each medication. So we can do a good job of reducing adverse drug events by reducing the number of medications, deprescribing, and polypharmacy for our elderly nursing home residents. So we know that adverse drug events result in hospitalization, cost a lot of money, result in unnecessary outpatient visits, and even deaths. So if we can reduce polypharmacy and start some deprescribing with our nursing home residents, we are going to reduce those adverse drug events. We're going to prevent hospitalization, we're going to save money, reduce unnecessary outpatient visits, and save lives. And as we all know, one of the most serious adverse drug events that a resident can experience is a fall. So everyone on this call knows that falls are a common cause of injury and death in our older adults, especially those who are frail or taking medications that increase the risk of falls. It's all too often that an elderly person falls at home and is unable to return, or in our nursing facilities, a resident experiences a fall and is sent to the hospital. Unfortunately, we don't see them again. So if we can reduce these adverse drug events and falls, we're going to improve the lives of our residents. Another thing I want you to keep in mind as we talk today is, as our body ages, it interacts with medications differently. So we're always on high alert when we're looking at somebody who falls for medication changes or what was newly added or increased. But we need to remember that just because a medication was tolerated at one point in time doesn't mean that later it's still being tolerated. A good example of this is long-acting benzodiazepines such as clonazepam or Klonopin, diazepam or Valium. So these medications are metabolized in our body, and those metabolites are eliminated through the kidneys. When we age, our decreased kidney function can result in those active metabolites building up over time and causing side effects. So while we might have tolerated a medication in the past, it doesn't mean that it's not contributing to side effects now. So we want to make sure that when we're looking at medication lists, we're looking at the whole medication list and not just newly or additive medications. Before we get into each of the medication classes and talk about different medications and how we might mitigate that risk for causing falls and other adverse drug events, we want to make sure that we have some sort of a fall risk assessment. So we need to recognize the risks. And the strongest predictor of future falls is if a patient has had a prior fall. So we need to make sure that we're looking at that when we're doing fall risk assessments and considering intrinsic and extrinsic factors. So for this presentation, we're going to focus on medications, polypharmacy, and deprescribing, which are extrinsic factors that we can control in order to reduce the risk of falls. But there are also several other factors, common causes of falls, that we need to make sure we're capturing in our falls assessment. Depending on what risk factors we identify is going to determine what intervention we put in place. So again, today we're going to talk about medications, decreasing or discontinuing them, where we could affect postural hypotension or oversedation from psychotropic medications. But don't forget about safety checklists to look at environments, activities of daily living, how the resident is interacting with their environment. Therapy can play a partner role in balance impairment. So it's all encompassing, and we need to put in multiple interventions in place to address the risks for the resident. So make sure, if you don't, that you have some sort of falls risk assessment within your facility. Utilize what you have at hand in your medical record. You should have a policy and procedure regarding when falls risk assessments are completed. And don't forget about pharmacy dispensing data. Sometimes there are ways where you can get the information about what medications your residents are taking. And as refer back to that first slide I talked about, every medication increases the risk of an adverse drug event. So a good rule of thumb to look at is how many medications each resident are taking, because the more they're taking, the more risk they are going to be for falling. There are also algorithms available for fall risks. SteadyRx is one, and I gave you a link there to go and check that out. So once we have a fall risk assessment, now let's get into talking about medications that can increase fall risk. So this is a list of medication classes that are high-risk falls for our elderly population. Anticholinergic medications, you may hear this term used quite often. We use it, refer to it a lot for medication side effects that we tend to not be able to tolerate as we age. This is commonly associated with a lot of medications on the Beers list, which are to be avoided in the elderly. But when you hear the term anticholinergic, think the common side effects are dry mouth, constipation, falls, dizziness, sedation, and hallucinations or other central nervous system changes. So those are the anticholinergic side effects when you hear that term that we're trying to avoid, and the ones that we tend to not tolerate as we age. Many antidepressants have increased risk for fall, some greater than others, and we'll go through those. Diabetic medication, so any medication that reduces your blood glucose is going to put you at risk for hypoglycemia, so low blood sugar, which can increase your risk for falls. Blood pressure medications often put a cap on our heart rate or our ability to compensate when we're going from a sitting to a standing position, so we can have orthostatic hypotension or bradycardia, which can contribute to falls. We have Parkinson's medications and antipsychotics, which both affect motor function. Antipsychotics affect our central nervous system and can affect motor symptoms by blocking dopamine. Benzodiazepines, as a general rule, we always want to avoid in the elderly. They have a high propensity to cause falls, in addition to injury after falls. Cholinesterase inhibitors are dementia medications like Aricept and donepezil, and those actually can cause bradycardia and syncope episodes. So we're going to talk about that. Our opioid analgesics, again, central nervous system depressants, so that sedation, the dizziness can result in falls. Sedative hypnotics, similarly, urinary antispasmodics. Think about any medication that we're using to treat that urinary incontinence. Those medications are highly anticholinergic, and so they're going to have a higher risk for falls. And then our vasodilators, again, are decreasing our ability to compensate, during postural changes. So when we're sitting to standing, can also contribute to dizziness and falls. Let's go into a little bit more detail into some of these categories. So first, opioids. So this is going to be hydrocodone, oxycodone, morphine, fentanyl, common medications we see in our resident population. So these medications are very effective to treat pain, and our strategy here for reducing our risk for falls and decreasing polypharmacy with the use of opioids is to always ensure we have plan to taper or a stop date is in place for our opioid medications. If we get a new admission, we want to make sure that we have a plan for tapering that opioid pain medicine, or a stop date is there if it's a PRN after an acute injury. If we have a new resident starting on an opioid, we want to make sure during that time when we're talking to the resident or their responsible party about the opioid medication we're going to use, we want to make sure that they understand what our plan is for tapering or stopping in the future. Generally speaking, we want to avoid the chronic use of opioids. If you do have a resident that's been on opioid medication for a long time, it's important that you dig into the chart. Good time to involve your pharmacist and your prescriber to look at why the medication was started and have we ever tried to taper off. We can come up with a very gradual strategy to taper off those chronic opioid medications. We need to know that taking an opioid scheduled for even 7 days, but once you get over 30 days, your risk of having an opioid or developing an opioid use disorder drastically increases. So we want to use these medications for the shortest duration we can. And if we have chronic use, we want to look at other alternatives and try to get a plan to taper. In addition, we want to try to avoid other central nervous system drugs because they're just going to make the side effect and adverse drug event risk worse. There's black box warnings for using benzodiazepines with opioid medications, but also any other medication like an antipsychotic, antidepressant, or other opioids. If we're duplicative therapy for barbiturates, we should try to avoid. And moving on to benzodiazepines. So in general, as it relates to falls, we should try to avoid benzodiazepines in our elderly population whenever possible. If we have to use one, we want to use it at the lowest possible dose for the shortest duration that we can. Short-acting benzodiazepines are not considered safer than long-acting. That used to be a concept. They both increase fall risk and both increase injury associated with that fall. the risk for injury. So our strategy here for these medications is to, again, use them at the lowest dose for the shortest duration. And then if we have a resident that has been taking, for example, lorazepam or Ativan every night for years, that's a great time to, again, bring in your pharmacist and your prescriber and come up with a very gradual tapering plan. It could be, you know, just adjusting the dose down slightly one night a week, and it could take several months to taper that off, but that is the one way that you can try to taper these medications off for someone who's been on them chronically. And then we have sedative and hypnotics. So the medications listed there are, you would know as Lunesta, Sonata, and Ambien. So these medications we should always avoid in our elderly population. They do not improve sleep, latency, or duration in the elderly. They don't allow us to get into REM sleep. So while they could be effective for an acute short-term duration to get us to sleep and give us some sedation, we want to avoid them if at all possible. So our strategy here would be, if resident is started on one of these medications or admitted on one, again, we want to look at non-pharmacological interventions. We can look at other medicines potentially, but we want to try to get a stop date or a plan to taper off them as soon as we can. Now, anticonvulsants typically used for seizure disorder or epilepsy are going to be Depakote, Keppra, so levetiracetam. You might see lamotrigine, carbamazepam, Vimpat. Those are anticonvulsant medications. Sometimes they're used for mood, but they're anticonvulsants, typically for seizure disorders. We should try to use them on label. And one strategy here for those medications that are being used for seizure prevention is, if you see, for example, a Keppra or a levetiracetam 500 milligrams BID in one of your residents that was admitted after having a stroke, but they don't have epilepsy or a chronic seizure condition prior to that stroke, that's a medication that we can target to deprescribe. That acute event of the stroke happened, and they are no longer in need of seizure prevention from that Keppra. So this is a common thing that we are able to intervene on in my facilities and taper them off those seizure medications. I will also stop just to quickly call out, we are all getting ready for the phase 3 guidance that's coming this fall. And so we need to ensure that with these medications, even though they're anticonvulsants or seizure medications, if we're using them for a mood, or if we're using, for example, Depakote for dementia with behaviors, we need to make sure that we're aware of the increased scrutiny that will be over those medications. They will be seen as psychotropics and under the same scrutiny and same expectations as an antipsychotic would be in that resident with dementia. So what's our strategy there? Well, we need to make sure that we know what the goal of therapy is. So if we start, for example, a medication like Depakote, we should know what we're hoping to accomplish with this medication. How are we going to monitor to make sure it's effective? And what is our plan in the future if it's not effective, or when are we going to stop that medication? So strategies around reducing those medications can involve making sure that they're actually benefiting the resident. So going back to the beginning again, every medicine that we're adding on top, adding in addition to our residents, is going to increase their risk for an adverse drug event, of which serious one is falls. So we want to focus on that deprescribing and polypharmacy bit. And in this scenario, we need to be extra vigilant with these anticonvulsants that we're going to be using off-label. And then antipsychotics. So again, central nervous system depressants. All the antipsychotics block dopamine. So if you remember from your pharmacology class. Parkinson's residents are low on, if you have a Parkinson's disease, you don't have enough dopamine. And if you think about antipsychotics, if you give somebody too much or too high of a dose of an antipsychotic, they have Parkinson's-like symptoms. So they could have a tremor, shuffling gait, blank stare. That's because we're depressing their dopamine. So we're blocking all their dopamine. So that's going to put them at risk for falls because of the motor function, but also the sedation. So in the absence of a compelling indication, so schizophrenia, bipolar, some DSM-5 type diagnosis, our strategy for these medications should ensure that we have a goal of therapy. Okay, so we know what symptom we're trying to treat, and that we are trying to establish the lowest effective dose. The American Psychiatric Association suggests, like, for example, if you're using it antipsychotic off-label in a resident with dementia, maybe for psychosis or something, that every 4 months is a good ballpark area to try that gradual dose reduction. And lean on your consultant pharmacist to work with your prescribers on making sure that we are doing a gradual dose reduction. We don't want to go too fast or too big of a jump down and have that fail. So our goal is always to get rid of these. They're going to reduce our risk for falls, but if we can't, we want to use the lowest effective dose possible. And moving on to antidepressants. So we have tricyclic antidepressants. Amitriptyline and doxepin are particularly higher risk because they're more highly anticholinergic, like we talked about. So they're going to decrease tolerability in our elderly population. So we want to try to avoid those or potentially switch them if we need an antidepressant. Our SSRIs, or selective serotonin reuptake inhibitors, or SNRIs, paroxetine or Paxil is the most anticholinergic in that class, so that's going to have the most risk. But all of those antidepressants, so SSRIs are like Zoloft, Lexapro, Celexa, the common ones we use. SNRIs are going to be like Cymbalta, Effexor, venlafaxine. So these are common antidepressants we use, but they all have some fall risk. And so our strategy here for addressing these antidepressants is to make sure if they are on a high risk one like amitriptyline or doxepin or Paxil, that we look at alternatives. And secondarily, are they still benefiting from this antidepressant? Do they still need it? We can look in our MDS at the PHQ-9 depression screen scores. We can look back to see when was that antidepressant started. Was it for an isolated incidence of depressive symptoms? Is the resident better? Were they just struggling a little bit and we started an antidepressant? A lot of these things we need to look at and really understand that the resident could just be doing better. An antidepressant might still be there, but they could just be doing better, not because of the drug, but in spite. And we're still putting them at risk for those adverse drug events. So we want to make sure that, because we're putting them at these increased risks for falls and adverse drug events, that they're still benefiting from all these medications. Skeletal muscle relaxants. These I see all the time added to medication regimens. They don't help because they're at too low of a dose and they just sit there. So make sure our strategy here is going to be looking at those flexurals, baclofen, tizanidines, and to make sure that we have some proof that when we started that medication for muscle spasms, that it actually helped. We didn't start something else 2 weeks later, but then never removed this medicine that we started. I see this very frequently where these medications are started for, back spasms or some other muscle spasms. They're not helpful, but they remain on the profile. And so our strategy here would be to, if we're unsure, let's try a slight dose reduction and monitor for symptoms. And then dementia medications, most notably like Aricept, acetylcholinesterase inhibitors. They do have risk for bradycardia, contributing to falls, and can have syncope events. And I have seen this commonly also where a resident in our memory care unit is falling. They're not benefiting from the donepezil or Aricept any longer. We remove it, and those falls reduced or got eliminated altogether. The strategy here is to look at those dementia medicine. You can use your BIMS score that's in your MDS at the nursing homes, but look to see if they're still likely benefiting from that. If their BIMS is less than a 6, odds are they're not benefiting from it any longer. You know, each person is different individually, so we want to make sure we look at that and involve responsible parties. But likely, we can remove that medication. It's putting the resident at increased risk for adverse drug events, but not helping them any longer. And a good strategy to use with family or responsible parties there is that there is evidence that if we do remove these medications and the person would get worse or cognitively decline, that we can restart them quickly and they will regain that back. That was an article published years back that showed a washout with Aricept. If you restart it, any losses will be regained. So that sometimes gives the family some comfort. Diabetes medications, again, the focus here is going to be on what's our goal. So if we have an 85-year-old resident with dementia in a long-term care facility, her goal, her hemoglobin A1C goal or her blood sugar goal is going to be different than a younger 50, 60-year-old person living in the community where we're still trying to be aggressive in that blood sugar and hemoglobin A1C goal to avoid potential later adverse events related to diabetes. Whereas a resident in our nursing homes, we're more focused on preventing hypoglycemia. So if their hemoglobin A1C goal was less than 7%, but now it's 8 to 8.5%, that might give us a chance to consolidate some of these medicines. They might not need to be on 3 or 4 anymore. We might be able to get it done with just 1 and still meet that goal. So the first strategy here with diabetes medications and to reduce that fall risk and reduce polypharmacy is to find out what the hemoglobin A1C goal is for American Diabetes Association. If it's a long-term care frail elderly resident, it's probably around 8%, which is a average blood sugar around 200, 180, 200. And then we want to look at their medicines. Are there things we can eliminate? Sulfonylureas like glimepiride and glyburide especially are renally eliminated. They are higher risk for hypoglycemia, so those are good ones to target first. We should avoid sliding scale insulin. We should be trying to decrease the number of finger sticks and injections for these residents and try to manage them conservatively with the least amount of medicine we can. That will reduce their risk for falls because they'll be less likely to have hypoglycemia, and they're also going to have better quality of life if they have less, if we're poking them less every day. And then important to look at our medications that increase orthostatic hypotension risk. So our blood pressure medications, our antipsychotics, our Parkinson's, tamsulosin, and other bladder agents. And we want to avoid non-selective alpha medications like prazosin, doxazosin, and terazosin if we're using them for hypertension. So here it might be a case where, during your fall risk assessment, we should have a way to check, some orthos at different times during the day to make sure that they're not experiencing a symptomatic drop in their blood pressure when they go from a sitting to a standing position. And if they are, we want to reach out and make sure we get a medication review, get some help from your consultant pharmacist, your prescriber, and figure out a way that we can decrease that risk for fall going forward. All right, just checking time here, still doing good. Common anticholinergics, we want to look at bladder agents. So if you think of any medications that we use to treat incontinence, with the exception of mirbitric, so oxybutynin, Detrol, Vesicare, they're all highly anticholinergic medications. That's the way that they work. So remember from the beginning, we're going to tolerate anticholinergics less and less as we age. So our strategy here is going to be to understand that these agents, when you look at how their impact on urinary incontinence, is that they may result in somebody having 0.5 to 1 less episodes of incontinence per day. So if we look at again, we can refer to the MDS in the nursing home or our bladder assessments. Are our residents still incontinent even though they're being treated with oxybutynin or one of these bladder agents? If they are, that medication probably isn't significantly helping them anymore. Like, is it helpful for them to have 3.5 incontinence episodes per day versus 4? Or would it be more helpful for us to remove a medication from them that's potentially causing them to have worsening constipation and increasing their risk for adverse drug events and including falls? Would that be in better use there of us eliminating that potentially unnecessary medication? So that's our strategy for that. If they're on those medicines and they're still having incontinence episodes, we could try to taper them off and get rid of them. And then antihistamines, especially non-selective. So your non-selective antihistamines are like Benadryl. The selective antihistamines are the ones we use for allergies like Zyrtec and Loratadine and Allegra. But the non-selective ones you're going to see in all the OTC sleeping medications. And again, as we age, we tolerate that less. We might be okay with a Benadryl at night now, but when we're 85 in a nursing home, we may not be able to tolerate those anticholinergic side effects. So we want to try to avoid those. If they are using them for sleep, we can try non-pharmacological interventions, find out if there's environment issues for why they're sleeping. Sometimes melatonin is effective, usually not, but we have other options. Hypertensive medications. Our strategy here for decreasing our fall risk is to, one, we've already talked about orthostatic hypotension, so we want to make sure they're not suffering from that. But also, what is our goal again? What's our goal blood pressure? Is it 140 over 90? Is it 135 over 85? What is it for this resident? And do they need the 4 or 5 agents they're on, or can we consolidate? Can we increase 1 or 2 and get rid of another one? Beta blockers commonly cause that dizziness and falls. Vasodilators we talked about reduce our ability to compensate. And then diuretics, we want to make sure we're dosing them at the right time, so not too late in the day, so we're not causing people to get up to try to go to the bathroom when they don't have help, or in the middle of the night. And then also to make sure that if they are on a loop diuretic like Lasix, that it's to treat edema and not hypertension. If they don't have edema, that'd be a good medication to try to decrease the dose or taper off of. So again, our strategy for blood pressure medications is, what's our goal for that resident, and can we get to that goal with fewer medications? So we hit on a lot of medication categories there, and I hope that I referred you back in general to that first slide where we talked about every medication we add is 7 to 10% increasing our risk of an adverse drug event, of which falls is a very serious one. And after somebody falls, we want to do a post-falls assessment, right? So we want to make sure that we're looking at their medication, and as I described earlier, we want to highlight any recent changes, but we want to look at all the medications in whole, because if we can stop or reduce any of them, we're going to reduce that resident's risk of future falls and deprescribing. So after a fall, involve your consultant pharmacist, your prescriber, look at all the medications the resident's taking. Are they still benefiting them? Are there any that we can consolidate? And I'd encourage you, even if you have a fall and you know it's not related to a medication, for example, they tripped on a slipper or some other reason, I'd still take that opportunity to look at those medications and try to prevent or reduce the risk for the next fall. I'm also going to encourage you today to think about ways that you could be proactive in reducing your fall risks. So I ask, why wait until a fall occurs to reduce polypharmacy? Can you identify high-risk residents prior to a fall? So at PharMerica, we have a fall risk calculator that takes into account all the medications that the residents are prescribed and gives them a numeric value based on their risk for falling. So this way, facilities can identify residents that are high risk based off their medications. So in combination with their fall risk assessment, which takes into account all the other things like environment, balance, activities of daily living, they can also incorporate a medication fall risk assessment. But even if you don't have a fancy fall risk calculator, you can still easily find out how many medications each of your residents are routinely taking. And you could use that to help you assess risk as far as what's going to happen in the future. So even if a new admission hasn't fallen, if they're on 15, 20 medications, you know they're at high risk, and it's that time to start looking at those medications. Is there anything we can deprescribing, any polypharmacy reductions that we can be made? And that's where you need to involve your consultant pharmacist and your prescriber. So my take-home message today is to make sure that we are reducing or eliminating as many medications as possible. Each medication reduces adverse drug event risk, which includes falls. Don't forget about OTC and dietary supplements. These are pervasive in our society today. They very rarely are required unless you're deficient. The over-the-counters and dietary supplements are low-hanging fruit that are typically quite easy to discontinue and get off the resident's profile. Just remember, they're not benign. They have side effects, they have drug interactions, and typically they're not needed by the resident. I also listed here some deprescribing references for you. So the Beers list is where a list of medications that we should avoid in the elderly. And then also there's conditions there. So diagnosis and comorbidities, medications you should avoid. Deprescribing.org has some really cool, good algorithms for specific medication classes and spells out exactly how to deprescribe. They have algorithms on proton pump inhibitors, hypertensive meds, diabetes meds, benzos, antipsychotics. So I'd take a look there. AMDA, Drive to Deprescribe. If you're not familiar with this initiative, check out their website. They have great webinars once a month, present very good, relevant material to our nursing home residents, regarding our nursing home residents and residents in long-term care. And it's specifically focused on deprescribing. Some very good information there. And then ASCP is American Society of Consultant Pharmacists. And they also have a lot of great information on deprescribing. So to wrap things up, before we get to questions, and I know Candy and Yvonne had some additional topics to bring up, I want to just thank everyone today for giving me the time. I want to encourage you to collaborate with your consultant pharmacist and your prescriber, your medical director, maybe at your next coffee meeting, and talk about what one step you might want to take towards decreasing fall risk and adverse drug events with your residents through deprescribing and reducing polypharmacy. Even if it's just, hey, why don't we start tracking the number of medications our residents take? Any little step like that to bring things and be more transparent will help you in this endeavor. And it really is a nonstop. Deprescribing isn't something you just do once. It has to be every day, constant, because it's always there and there's always opportunity. With that, I think I'm going to turn it back over to you, Candy.
Thank you, Dr. Palmer. That was extremely helpful and a lot of information for people as well. Jess will be dropping the evaluation link into the chat. And Yvonne, unless you had something to add, I think we'll let Jessica go. Oh, Jessica just dropped it in the link. Thanks, Jess. And so, Jess, do you want to start running through the list of questions? And again, if you have questions now, please.
One thing, Candy, before Dr. Palmer, Dr. Palmer, can you give a high-level explanation of the phase 3 guidance?
Sure. So, well, the phase 3 guidance that is medication related or pharmacy related, there's various aspects. One, they basically gave direction on fentanyl patch disposal, so they updated that. They updated the guidance and basically increased the scope of what they consider a psychotropic medication. So it's really defined as any medication that's used as a psychotropic or for a behavior. CMS will consider a psychotropic medication. So it doesn't matter what class it is. So if you're using hydroxyzine for anxiety, for example, that's a psychotropic medication. If any medication you're using for a psychotropic reason will be under the same scrutiny as an antipsychotic, for example. They also said if a medication is a psychotropic medication, if it's used for a non-psych medication, it doesn't matter if it's an antipsychotic, anxiolytic, antidepressant, or sedative hypnotic classified that way, it's going to be considered a psychotropic. So this is going to impact Cymbalta for pain. Even though it's used for pain, it's still a psychotropic, and all guidelines pertain. Lorazepam or diazepam for seizures, it's still a psychotropic, and all psychotropic regulations pertain to that. So that was kind of the big one that they did. They also called out misdiagnoses related and said they're going to be paying a lot more close attention to the diagnosis and why we're giving what we're giving, because the diagnosis should come first, not the medication. They cited examples where residents with dementia had orders for antipsychotics, and the diagnosis was later switched to schizophrenia so that it wouldn't hit the quality indicator report, basically, the quality measures. And so they're going to be looking very closely at, to make sure that the medication didn't get started for some other reason, and then the diagnosis came later. The diagnosis or evaluation should come first, and then if we decide to treat, the medication should come second. They also clarified the gradual dose reductions to say that they should occur in modest increments over an adequate period of time. So instead of, it used to say it's still, so twice within the first year in 2 separate quarters may still fulfill that guidance, but they just added that we need to make sure that we're doing modest dose reductions over adequate amount of time. That's kind of high level, the bigger changes.
Thank you.
All right, I'll ask the first question from the chat if everyone's ready. Which residents might be the most likely to develop signs and symptoms of withdrawal from opioid, or does the taper plan take that into account? And kind of going along with that, what would be the interventions for someone displaying withdrawal signs and symptoms from opioids?
Yep, good questions. So the longer somebody is on an opioid, the smaller taper and longer time, the slower taper basically we're gonna need to go. So it might be as small as like a 10% reduction. You might take someone who's on something TID and you might make it BID just 1 day a week. for a couple weeks. So the slower you can go, the less risk you have for withdrawal symptoms. If they do experience withdrawal symptoms, you just go back to that previous dose, or you can potentially have some sort of like a as needed dose to accommodate them as you slowly start to taper down. But if somebody's been on a chronic opioid, yeah, we need to just go slow over a long period of time. And it's okay if they do have withdrawal symptoms and we have to go back. It doesn't mean we can never try again. It's just they haven't gotten used to that lower standard dose.
Thank you.
Mhm.
I will move on because we talked about phase 3 guidance already. Does the every 4-month frequency interval apply to all deprescribing efforts, or are some more priority than others?
I think that every 4 months came from the slide on specific to antipsychotics when used in residents with dementia. And that comes from recommendations from the American Psychiatric Association that are referenced in the CMS guidelines. So that's from there. In general, it really depends for deprescribing on the medication you're using. For example, Aricept has a very long half-life, so you can just discontinue it and it gradually tapers. It takes 2 weeks before it's out of the system. Fluoxetine, like an antidepressant, the same thing. You can just discontinue it and the long half-life gradually tapers on its own. Other medications you need to, taper. Bladder agents, typically if they're not effective, we just get rid of them. There's no problem. Proton pump inhibitors, you typically need to decrease a little bit to avoid like a rebound GERD symptoms, or you might want to use a PRN for a little while of like a Tums or something. So it really depends on the agent. But that 4 months is really specific to antipsychotics in residents with dementia per the American Psychiatric Association guidelines.
Thank you. The next question is, if someone comes from the hospital on sliding scale insulin, is a pharmacy consultant the most effective intervention for getting off of that?
I don't know if it's the most effective. Definitely an option to involve your consultant pharmacist on how to approach that. I think, you're still going to need, unless you have some sort of collaborative practice agreement in place, that the pharmacist can get orders put in place. You're still going to need a prescriber to be able to write those orders. So it could be that you involve your consultant pharmacist and help collaborate with your prescribers to start an effort that when you get an admission on sliding scale, that during that first visit, if the prescriber would like the consultant pharmacist to give them recommendations on how to get them off the sliding scale so that they can follow them, that might be one intervention. We could talk about, ways to eliminate sliding scale insulin after admission in the other form. So I think really the best route is to collaborate with your consultant pharmacist and the prescriber in order to see how best to go about, what works for your facility. Do you have a nurse practitioner that comes in on day 3 after admission? Or are you waiting until the primary care provider sees them? When does your pharmacist get involved? Do they do a new admission review, or is it not till they have their monthly visit? So I think that timing is going to vary a little bit depending on who's the best to start it. But one thing to remember is it can be a gradual process. Somebody might stay on sliding scale for a couple of weeks while you're figuring out their mealtime dosing, just to give them coverage. So that one can't be like an all or none type recommendation. But good question.
Thank you. That is all of the questions that we currently have. If anyone else has a question, please add it to the Q&A box or in the chat. And I will hand it back over to Candy for now.
Sure, and I think, thanks, Jess, and thank you, Dr. Palmer. Yeah, so if you do have any final questions, we'll just hang on for another minute or so to see if someone has additional questions. And otherwise, we will conclude our webinar. So let's just hang on for 1 minute.
Dr. Palmer, I just have, it's just reiterating what you said, and thank you so much. So just from everything we've learned today, my understanding is the greatest intervention is to taper the medications and then see if we can DC them, and that should help with falls, correct?
Yes, from a lot of interventions, other non-pharmacological interventions you can put in place, but from a pharmacist perspective, focusing on the medications, deprescribing, and just reducing the number of medicines will reduce the adverse drug events. That is a good summary, and a take-home message is that, and I say this, I get falls, reviews all the time where this resident, rolled out of bed. Can you look at their medications? Well, the medications might not have directly caused that fall, but it's still a great opportunity to look at their whole regimen and really ask the question, do we have good goals? Are these all needed? Are they still benefiting the resident? Because we know that there's a cost associated with each one of them, because they're each contributing to the adverse drug event risk and fall risk.
Thank you. We have one more question in the chat. These tapers sound good for long-term residents, but what about the short-term acute residents who have specialists, such as an outside endocrinologist, psychologist, cardiologist, that require very specific drugs for this resident?
Sure. Yeah, that's a good question, and it is tough for a short-term resident to be making big interventions that take time, right? Because the resident may only be there for a couple of weeks. I think it's still valuable to at least send, if there are concerns about, polypharmacy or opportunities that you see for deprescribing. If the resident's going to be short-term, or you don't have the ability to discuss with those outside providers, I think there's still value in discussing it with the resident and making sure that they're asking those questions to those providers the next time they see them. Those physicians, those outside endocrinologists, psych, and cardiologists, they should be able to tell you why you're on every medication you're taking. The provider doesn't know or isn't sure just because they didn't start it. That's not a valid reason. They should be able to tell you why you're on it and how you're benefiting from it. And so I think empowering the residents to ask those questions is one way to go about it.
Yeah, I think that's fantastic advice because it's always great when we empower our residents and to help with the decision-making process. So, Jess, are there any more questions in chat? I did not see any.
Nope, no other questions at this time. Thank you.
All right, well, Dr. Palmer, we want to thank you so much for this presentation. It was filled with such great, rich information that will hopefully benefit all of us. And just thank you so much for presenting with us today.
Absolutely. It was a great time. Appreciate the opportunity. And thanks everyone who participated and listened today.
All right, thank you. So the evaluation link is still in chat. I believe we'll also be sending it out with the slides that will be coming out shortly after this event. And thank you everyone for joining us today. We really appreciate it.